Hi, my name is Caitlin Bangeter, and for my first case study in our vascularity class, I decided to do it on Baker cysts. So, the case study I found was about a 55-year-old male who had just recently returned home from trekking in Nepal. He had been complaining of some posterior knee pain that he had had upon returning. He was also experiencing some tenderness and some swelling to that knee joint. He went to go get it checked out, and clinically he was diagnosed with a minor knee fusion, but had to undergo some more imaging exams to just further diagnose his presented symptoms. So his doctor was concerned of the following different diagnoses and some different pathologies. So it could either be deep vein thrombosis, a calf muscle injury, a Baker cyst with rupture or without a rupture. There might have been some soft tissue tumor, some cellulitis, or an abscess, are all things that the doctor was maybe concerned of. So the patient ended up undergoing an ultrasound examination, and it was determined that the patient was experiencing the effects of an unruptured Baker cyst. As you can see in these two images here, the protocol is usually done in two different planes. So we have our transverse view on the left and then our longitudinal view on the right. That way you can get at least two views at 90 degrees to see all the pathology that you can see. Obviously, you scan through the entire pathology that is seen to make sure that you're not missing anything and miss a diagnosis. But normally with Baker cysts, they have the common speech bubble appearances, so they call it, where it just kind of looks like a little talk bubble. So what is a Baker cyst? I'd always heard of a Baker cyst, but I guess I didn't really fully know what a Baker cyst was until after researching. A Baker cyst is a fluid-filled sac. It arises between the medial head of the gastrocnemius muscle, which you can see here is this broad arrow. It lies between the gastrocnemius muscle and the semimembranosus tendon, which you can see here with the curved arrow. And the blue area, of course, being the Baker cysts. Baker cysts are known to have thin and well-defined walls. They are full of an anechoic fluid, and the most common age range that someone can be diagnosed with a Baker cyst is somewhere between 35 to 70 years old. And our patient, who was 55, fell right into that category. Baker cysts can also be known as popliteal cysts, as they lie in the popliteal region, which is the posterior aspect of the knee. How do Baker cysts form? Baker cysts are associated with forms of arthritis or ligament, meniscus, or cartilage damage to a knee. These are all causes of excess buildup of synovial fluid in the knee joint. So all that fluid builds up in the knee joint. In this diagram here, you can see there's quite a bit of buildup of synovial fluid, and that fluid has to go somewhere. So to decompress the synovial fluid kind of creates this little tunnel, as seen right here. And that tunnel is created to form a periarticular cyst just outside of the joint, which can be seen at this structure here. The tunnel is a one-way flow valve, so that the fluid cannot run back from the cyst into the synovial joint. The fluid that is trapped in the Baker cyst will be later reabsorbed by the body through the semipermeable membrane that the Baker cyst has. You can see these little arrows pointing, showing that the fluid will just eventually be reabsorbed into the body. So some common symptoms that patients have with Baker cysts is a palpable bulge in the posterior aspect or the popliteal region of the knee. They may experience some tightness behind the knee, some knee or calf pain when flexing or extending the knee, some swelling, And symptoms may be worse after being active or standing for a longer period of time, which also matches to our case study patient of after his long hiking trek in Nepal, that he would experience these symptoms. So, like we stated earlier, our patient was diagnosed after an ultrasound exam. One of the main reasons the ultrasound is used to diagnose Baker cyst is because of color Doppler. The color Doppler can be used to show the vascularity that is in or around a cyst. This particular image shows no internal vascularity, but if it did, it would be concerning of a more complex solid mass. This image just shows normal vascularity on the peripheral of the cyst, as you can see the little flashes of red and blue of the vascularity around the cyst. So anytime you have a lump or a bump, or a palpable bulge behind the knee like a Baker cyst, I guess it could be always diagnosed as multiple things, but at least using ultrasound you can see if there is a difference between the cyst or if it's a mass by the vascularity that can be shown. Another way to diagnose a Baker cyst is by using ultrasound. Additional way to diagnose a Baker cyst is by MRI. Even though ultrasounds are preferred to image Baker cysts, MRI is another helpful way to diagnose them. Here you can see kind of an axial view through the knee joint and then a sagittal view of that same knee. Ultrasounds just tend to be a little bit more helpful to detect the extent, the content of what is actually inside the Baker cyst, and if there was any recent leakage from a rupture of the Baker cyst. On the rare occasion, Baker cysts may rupture, sending fluid inferiorly down the calf. From my studying and researching on this, I found that it's a common symptom for when a Baker cyst does rupture for the patient to feel the sensation of running water down their leg, as that fluid is making its way inferiorly down the patient's leg. The leakage can cause localized knee pain. It can also cause redness of the calf, which is also similar signs of a deep vein thrombosis in a leg, which is an emergent situation. So it's always good that if you are having these symptoms to get that checked out immediately in case there is a blood clot. So treatment, there's kind of a wide variety of treatments. There's the simple at-home treatments, which is rest, ice, and use compression bandages. Baker cysts can be aspirated. It depends on how thick the fluid is. If it has a high viscosity, they don't like to do an aspiration just because the fluid is so thick. Also, when it is aspirated, there is a high likelihood of it reoccurring and happening once again with that fluid buildup. Another thing is physical therapy, and probably the most common treatment is actually treating the underlying problem, which is usually provides the patient relief. So like I said before, if they have arthritis or ligament damage, it's easier to treat that underlying symptom, which will also help treat the Baker cyst. It can also be treated by steroid injections. Surgery is rarely needed but can help if the overproduction of the synovial fluid is because of a cartilage tear. If the cyst has ruptured, the fluid can be just reabsorbed into the body over time. Also, if the cyst has ruptured, it is important to just rest and elevate the knee and just kind of give the time that it needs to heal. So for our case study patient, the doctor recommended the patient just rest. They did an aspiration of the fluid as more of a therapeutic thing to help get rid of the pain and the palpable bulge. And the patient was also recommended to have some physical therapy. Since there wasn't really any underlying causes noticed in the patient's examinations, the Baker cyst was likely occurred out of overuse and exertion from the patient's recent trip that they took. The physician did tell the patient, though, that if symptoms did start to occur again, that an MRI of the knee may be beneficial to further examine knee pathology that might not have been seen on the ultrasound. And that is it. There's my works cited, and thank you.